Were you into lifestyle before you started this association, or you have started all the projects simultaneously, or you have a super team which is working on different areas of lifestyle medicines simultaneously? This is my question to you.
No, I haven't worked with lifestyle medicine before. I was approached by the Lifestyle Medicine Global Alliance before COVID came, and I couldn't do anything during that time. So when the COVID subsided, I started to collect my friends, doctors, and dietitians, and so on and so forth, to come together, and we formed this association. At that time, we not quite know where we should proceed. So I thought that the best way is to find people who know what they're doing already. The dietitians, the nutritionists, the physical therapists, the psychiatrists, and so on and so forth that are involved in the 6 pillars. And I went personally to talk to each of the eminent members of those associations myself. Took a lot of time and a lot of communication. And we brought them all together. They don't know each other. They are separate entities altogether. We are working as connected, and we ignite some issues. And I think we managed to gather them together, and they listen to us to a certain extent. I think we're in a position that we can launch something that can at least solve part of the problem of the country if we can. So I think, for example, the psychiatrists, they want to do things on the social media effects upon the families and the children. I think they've been doing it on their own. And I think if we have the power of a group like this, a lot more can be done. To tell you the truth, I worked myself for the initial part, and now we are starting to set up this subcommittee. So I'm finding the young people to come and take the lead. I help advising them, but they're now running some of the projects like the PM 2.5 projects. I think there are collaborations about to take place on the diplomatic side as well as on the military side and university side. So we are trying to see where we can fill in the gap in terms of the preparation of the population readiness for the season. And for the aging population, for instance, I talked to one of the institutions in Thailand, and they felt the need that we need to change the mindset of the people, not only the government side, but also the private sector. We tend to feel that the elderly people are the cost to the country. As soon as you retire in Thailand at the age of 60, they become a cost because they go into retirement, disappear, and they have to depend on the social welfare. We want to change that. I think it's time to look at the age of retirement. 60 may not be the right time because I'm 66. I'm still working like a 30-year-old person. Working much harder than when I was young. I think we can contribute. Thank you. I think we can contribute significantly to the society. At the age of 70, a lot of Thai people, Thai doctors, still working at the age of 75. I think it's time we have to revisit this particular aspect, and also we need to provide tracks for these retirees. In terms of appropriate job for them. They want to do something part-time. They can use their brain, their experiences, and they can create money, revenue for the country. We give them the tools to do so. In Thailand, we have 1 million persons retired every year. 10 years have 10 million people, and not many people will die during those 10 years. So you have something like 9 million people left that can create a lot of revenue for the country. It's just the way we have to approach these people, change our own mindset and what we can do. So this is something that I think it involves a lot of people working together to achieve this. And very soon we'll have subcommittee working on that with the young people working in this direction on behalf of the association and other organizations. Thank you.
Thank you very much. Has Dr. Sheila joined us?
I don't think. I think current panel, the other event that she mentioned is still ongoing.
Sure.
So unfortunately, she's not here yet.
Sure, no issues. We have a lot of conferences going on parallel right now. Indian Lifestyle Medicine Conference is going on as well. So, yeah, do we have any question from the audience?
Any questions from the audience? Anybody? Any kind of question? Anyone know?
May I give a short statement here to give praise to the organizer of HARM. I think it's very impressive indeed. I watched the conference a bit early on before our session. Very impressive.
You were online attending a conference?
Early on, just a few hours before. Yes.
Oh, good.
To see.
Good, good. Do you want to ask any question?
Very impressive.
Any question, any comment? Anybody? Yeah, you have the privilege to get a question from Dr. 𝗂𝗟𝗂𝗲𝗲, who has come from Doha, while Cornell University. So she wanted to ask you a question.
Yeah, hello. Very warm welcome to you into the Lifestyle Medicine Collaborator Group.
Thank you.
So inshallah, we are looking forward to come to Phuket next year. So,
yes.
yes,
Yes.
so I hope to see you there.
Yes,
So
I'll be there.
I was just, I mean, I visited Bangkok several times now, but I'm just curious, what are the kind of challenges that y'all are facing in healthcare? Is it more the NCD burden? Are y'all also seeing it? I mean, we generally tend to think that the Thais have a very active life, you know, they eat well, a lot of plant-based food. So what are the kind of challenges that are the reality there?
I think the same like in any countries. I think we over-consuming. I think we're eating too much.
Sure.
I think we take things too easy sometimes, too
Right.
relaxing.
Right.
Exercise. I think a lot of people still don't do enough physical activity,
Okay.
and so I think NCD are still the main problem.
Right. And are you seeing, even in the younger age group, are you seeing a lot of sedentariness, like in young children, and obesity, overweight, pre-diabetes? Is that also?
Yes. I think we see more and more, and we have a lot of obese children in our society. Big problems. I think we still need to find way to promote the change on that. And I think education for the family still very essential.
Yes.
We still need to do a lot more.
Sure. Okay, great. We're in this together.
Oh, I look forward to meet you in
Yes,
Phuket.
me too.
Thank you very much.
Thank you.
Thank you.
Okay.
And there's one question from the audience. Someone has put their hand up.
I think the virtual audience, he means. The virtual audience.
Could be
Yeah,
an
that's
online
right.
question. Yeah. Online, we have a lot of participants online.
Hi, can you hear me?
Yep.
Yeah, so I am Dr. 𝗂𝗟𝗂𝗲𝗲𝗲𝗏. I'm a lifestyle medicine consultant in Cleveland Clinic, Abu Dhabi. And unfortunately, I couldn't come due to certain reasons. So I just have a question with the captain that what kind of issues did you have in creating this society? Because in the UAE, I think the challenge is that they're not allowing us to create this society because lifestyle medicine consultants or coaches or physicians are part of different entities. Did you face that as a challenge with the Thai Department of Health, or if you could enlighten that for me, please?
In Thailand, I think you can set up association if it is related to medicine, then you have to go according to the official process. The department, the Ministry of Interior is responsible for registering the new association, and that's what we did just that. And then ask for suggestion and advice and recommendation from the Ministry of Public Health. So we went through that pathway, and then we returned back that they agreed to the setting up of our association. Our association is not completely lifestyle medicine. We added the word and well-being into it as well. So we not only cover the medicine side of things, but we are looking at other aspects that related to well-being, which involve many specialties, involve many other health-related fields. So is a bit wider than medicine. I think in Thailand you can have association with similar objectives, but slightly different details. For example, you have the foundation for or association for horoscope for people looking at the fortune of the people. That they have 3 or 4 different associations for that. But for medicine, mine may be a little bit different from the other medical association, that we have other aspects be added into the function of our association. But in Thailand, I think you just go through the process, and the official, the Ministry of Interior, will then consult any particular ministries that may be concerned with your mission to get the approval and suggested advice.
Okay, thank you so much. I really appreciate that.
Welcome.
Thank
We'll
you
try our
very much.
best.
Thank you very much to our
Good luck.
panelists.
And can I ask a quick follow-up question from Dr. Ahad? Is it about is the problem about establishing an organization as a society or as an association, or about creating a college or a medical discipline?
So it's basically both. So that's what we wanted to do. We wanted to start off with creating an association or a society, and then of course, get that approved as an entity, separate entity, a lifestyle medicine as a separate entity. So I understand that as a separate entity might be difficult because it's incorporating many different fields, but even the first step of creating as a society was taken back. And we're trying, we're basically in the moment of creating a fellowship program, which is in the process of being approved. So I think we'll just take those baby steps. But I think it's the need. That's where we will cooperate with or get together with other people.
I think you can, because most likely you'll need some kind of legal support. Like for instance, I can give you some scenarios. For instance, in Singapore, when you look at the Companies Registration Act, that is a very restricted pathway for non-profit organizations. But whereas there's a separate provision from Social Affairs Ministry, so you can register as a society without much of a scrutiny or any unnecessary government intervention. You can organize and create things in a non-profit manner and maintain things legal. So that is a constant thing that we have seen across most of the countries. In Sri Lanka, for instance, same thing. Article 34 is particularly for non-profits, but there are a lot of barriers. But none of these things are going to be a barrier for you to establish an organization per se, like just to get together as a group of people for a common purpose. And only place we have seen in Asia that had significant trouble was in China, where you need to establish at district levels. But I don't think it'll be that bad in where you are coming from. So that's the part of the organization part. The medical discipline is a long story, but I think maybe thinking or maybe getting some advice, legal advice as to, because usually every country has more than one pathway for creating organizations, associations, societies, civil organizations, etc. So maybe it's a good idea to see, get some.
That's a very useful
advice.
That's a very useful advice. Of course, thank you so much. I really appreciate your feedback as well. Yeah, and I'll get in touch with you if you need any more information. So if you're okay with that.
Absolutely. Anytime,
Thank you.
please.
Rahat, I just wanted to apologize that you got so much inconvenience and you couldn't join the conference. And we were really looking forward for your arrival in our conference. I hope you have attended few of our sessions as well. Did you?
I did actually. Yeah, from this morning I have. Today's session I've attended, and I'm really gutted because I was actually really looking forward to meeting you all and getting connected and coming to my own country. I was very, very excited.
Okay.
But unfortunately, it wasn't meant to be. But obviously, it's the beginning. So it's the beginning of our collaboration. So I'm looking forward to future meets.
Okay. Thank you, Rahat. Thank you very much.
Thank you very much. Thank you very much. Thank you to all the panelists. Ma'am, would you like to say a few words?
I would like to say thanks, a very, very special thank you to Samantika, because we took this decision, I think, few days back, and the amount of stress I think Dr. Zia and I have given you, and and then you have prepared the presentation and panelists. So I can imagine what added stress you have been through while preparing for this Asian panel, which is the first time we have done. And we are lucky, PALM and RLM is lucky that we have done this Asian panel session in a conference, in Asian conferences for the first time. So thank you, Semantica, and thank you, Dr. Yongyu. It was lovely. And I would like to give you a very, very personal comment. Both of you, you both boys were looking very handsome on our screen. So thank you very much. Thank you. And my special gratitude to Sheila as well. I know she would have definitely be in a serious condition or situation. That is why she couldn't join. Thank you once again.
And thank you very much, Pakistan Association of Lifestyle Medicine, for giving us the platform. And this is the first annual forum that we had after reorganizing as the Asian Council. And once again, thank you, Dr. 𝗟𝗏𝗳𝗏, Dr. Abbas, and Dr. Yongyu.
Thank you.
Have a great day.
Thank you very much.
Right, I'm back, but not for long. I promise you that. Yes, yes, and coffee as well. Right. Thank you, everyone. Thank you, speakers of Asian Lifestyle Medical Council. It's nice to see that so much work is going on in lifestyle medicine, which is the future actually. So, when I was a young student, medical student, I think that is when it was. At that time, I watched a movie. I don't know whether anybody of you would have seen that, A Walk in the Clouds. Beautiful movie. So walking in the clouds of my medical profession as a young doctor, I stumbled upon a beating organ and ended up managing its dis-ease, not disease, dis-ease, and became a cardiologist. And whenever I see another cardiologist, it reminds me of the verse, हम अकेले ही चले थे जानिबे मंजिल मगर लोग साथ आते गए और कारवां बनता गया. So our next speaker is also from the specialty that I come from. And perhaps long before me, he realized that to truly serve the suffering humanity, we need a paradigm shift. And thus, he chose prevention. Dr. 𝗟𝗏𝗳𝗏𝗏𝗧, a graduate of King Edward Medical College, is a leading cardiologist with expertise in cardiovascular disease prevention. After training in the UK, he established a renowned cardiology program at Aga Khan University and now leads the Department of Preventive Cardiology at National Institute of Cardiovascular Diseases. He has coordinated multiple international research projects and published over 75 peer-reviewed articles. Dr. 𝗟𝗏𝗳𝗏𝗏𝗧 will address challenges in cardiovascular disease prevention, a lifestyle medicine approach. Sir, if you would kindly come to the stage. Thank you.
Okay, thank you very much, and thank you for inviting me here. I'm a student here, so I'm learning about lifestyle medicine. So this is just first exposure to lifestyle medicine. Although the things which I've been talking about as prevention are not very different from what have been talked about here. So, okay.
Presentation.
Okay. So I'm going to be talking about the challenges which I have faced over the years, and which now I think are the major stumbling blocks in a road of prevention. And as far as disclosure is concerned, I think my only conflict of interest is that I am an cardiologist. But I think I kind of tried to move that conflict of interest few years back when I changed my path from interventional cardiology to preventive cardiology. Okay, so as far as the volume of cardiovascular disease in Pakistan is concerned, I don't think I need to go into the details. We all know how challenging the situation is in Pakistan. We have multiple numbers, issues from global study, which talks about the increasing number. And I think here it's not the issue that ischemic heart disease is number one. The number at that right corner is more alarming to me, which shows that how rapidly things are changing. And in fact, I think in Pakistan, this is one thing which we are progressing so rapidly that we are beating all the estimates. So diabetes, we estimated it will be somewhere where in 2030, and we already crossed that mark, and same is true for cardiovascular disease. The other worrying thing, which we all know, we increasingly seeing the problem in younger and younger population. Way back in 90s, we had an InterHeart study which did show that in South Asia, the age of first AMI is about 10 years younger than the Western population. And interestingly, I think the South Asian study, then sub-analysis, it concluded that the reason for premature coronary artery disease in our population is the risk factors or accumulation of risk factors in our younger population. We have a recent data from I apologize. I mean, this is from NICVD. This is a data of about 4,500 patients who were admitted with an acute MI. And I mean, especially at NICVD, we admit about 30 to 40 acute ST elevation MIs every day. So it's a massive number, I mean, mind-blowing number. And out of these significant number, about 10% were less than 40 years. Okay, and so, I mean, if you would see here, the reason that was standing out as a cause for acute MI at a younger age was one, smoking, and second was positive family history. Right? So that's something which, I mean, Jabbar was earlier talking about, I mean, the high risk approach. I mean, I think that gives us an idea that where we need to work at. So if someone has a family history of coronary artery disease, then you start worrying about not after the age of 40, maybe right from the school age or at the time when they start growing. We all know that. I think InterHeart showed that as well, and now this global burden of disease study as well, that over 90%, like here we say ischemic heart disease, 94% of this ischemic heart disease is related to preventable risk factors. Okay, so we know that for last 25, 30 years, we haven't been able to change anything, unfortunately. The trajectory keeps on going the same way as it was going now. And this is an old slide. Somewhere, I mean, in 2010 or 11, this was a World Bank report. And very interesting at that time, the figure you're seeing is male and females, red and blue, and 2000 on the left side and 2025 on the side. You clearly see a change in the shape of pyramid. So what does it mean? That at that time in 2020, our almost 80% of population was under the age of 30, whereas now around 2025, our 60% of population is between the age of 15 and 60. So a very large number of population which is in that category, which we can say is a very productive age for anyone in society. And that's exactly what the World Bank talked about for South Asian or Southeast Asian and South Asian countries, that this could be an opportunity because you have a lot of young population who are going to become a productive population. But unfortunately, what we have done here is that rather than making them productive, we have a very large diseased population, unfortunately. So these are the numbers from Global Burden of Disease Study. So I have just tried to kind of put those percentages into numbers so that kind of sometimes I think percentage does not really strike us. I mean, 45%, so what? But I mean, see the number of hypertensives we have, 55 million, diabetes, 33 million, cardiovascular disease, over 900 plus 100,000 per 100,000 population. Obesity, 9% are obese, but 22 million are at a risk of obesity or overweight. 52 million, 5.4 million school children are overweight or obese. So, I mean, this is the population which is going to become our future. And that's what Jabbar was talking about, that if we need to do something, I mean, this is an area where we need to work. Obviously, I mean, no question. And again, I think well-known figure that cardiovascular disease with all those that disease burden, it becomes a vicious cycle of poverty. I mean, when I started talking about this cardiovascular disease prevention, one of the things which I started saying, I mean, I think having, everyone was saying about, look, our infant mortality is so high, which is unfortunately still very high, unfortunately. I mean, but I would say, okay, when an infant dies in a family, it's a psychological trauma. But if God gives you another child, most of the parents will overcome that and move on with life. But if a 45-year-old breadwinner of the family has a heart attack and becomes incapacitated, the effect on the family cannot be corrected again, right? So the socioeconomic burden of cardiovascular diseases at a younger age is so massively high compared to what we are talking about. And I mean, okay, let's. Okay, and so this is what causes poverty. This is a study which I also had the privilege of being part of. This is still ongoing study. This is called PURE. It's an urban-rural comparison of studies and long cohorts. We have a follow-up of over 20 years now from an urban cohort and a rural cohort. And the purpose of showing this slide here is not, I mean, a lot of things which are shown here, but what I trying to show is that in our population, we have high incidence of risk factors, but unfortunately, our mortality rate from those risk factors is highest in the South Asia, more than India, more than Bangladesh and Nepal. Why is that happening? Okay, let's talk about that. Okay, one of the issue is this economic scenario, and this is a study which was published in 2020. A group from Faisalabad has done that, and they studied the availability and affordability of essential medicine for cardiovascular disease. So, I mean, these are numbers which they could find at that time of original brands and also Me Too's which are available here. So the LPGE means the lowest priced product of that particular drug. So if it is bisoprolol, whichever is the lowest brand available. So minimum cost of essential medication after having an MI or after having a stroke is about 3,500 rupees per month. And if a family is earning about 30 or 35,000 rupees a month, imagine how would he or she, one person, spend 3,500 on one individual just on medication. We're not talking about school fee. We're not talking about food. Food basket price for one person for 1 month is at this time almost around 5,000. So either he will have to starve the children and take his medication, or leave his medication and starve. So not I mean, surprisingly, that outcomes of hypertension are a lot worse in our population. We get a lot more strokes than our neighbors in India, because of the cost and the healthcare system. And talking about, so this is the story which my favorite. I mean, this is what made me change my heart. And I suppose, I mean, people here, they already changed. So, but I would still like to read this story. So one day I was enjoying my weekend by the side of a stream when I suddenly heard a scream of someone drowning. I jumped in, dragged him out. While I was applying CPR, I heard another cry. I jumped in again, brought him out, and as I was resuscitating him, there was another cry. I jumped in again, and then another cry, and then another. I was so busy trying to save these lives that I had no time to think who the hell was pushing them in. So this is the story which I tell my cardiologist colleagues as well, and other specialists as well. So we need to think about what is happening upstream. And no question that we need to talk about preventing the problem rather than treating the problem. We all know, I mean, again, I think we don't have to reinvent the wheel. We know about what steps we need to do, primordial, and secondary prevention. But our response, unfortunately, at this time, our health system response is that we are just applying CPR. We are happy to establish cardiovascular state-of-art centers, but none of those have any preventive cardiology services. We are happy to establish cath labs and do top-of-line procedures, and I mean, take a pride that, look, we do the same procedure as someone is doing sitting in New York or Washington or Paris or London. But we don't think of what cost we are getting and what are the benefits of the procedure we are doing. Primary PCI, the reason I'm saying is, I mean, NICVD takes pride in providing a free of cost primary PCI service across the province of Sindh. Tremendous service, obviously. Everyone who gets a heart attack, he has the right to have a primary PCI in a timely manner. But is that enough? What about preventing problem after we had put a stent in? So we need to think about all this, because unfortunately our health system in Pakistan, and I think someone from Thailand with it talking about the same thing, is disease centric and acute care related. We're not concerned about what is causing that acute problem. We are, I mean, I think machine लगाने में और फीता काटने में जो pride मिलता है, वो I think we are still following that rather than trying to see how to address that. Okay, so just a glimpse of, I mean, again, today I think when I was going to talk about health system, I was going to say, I mean, someone can ask me, what are you talking about? You're talking about system out of a period of chaos. What we have witnessed today and yesterday, I mean, what system would we be talking about? What we can say that, but anyway, these are the facts that we have. Over 250 million population, age standardized death rate significantly higher than the global death rate, and dismal health facilities. We have more doctors per patient than nurses per patient, unfortunately. It should be other way around. And public sector health spending, you can see, I think a lot more is spent on putting the containers on the road rather than putting the containers on the way of the disease, unfortunately. I mean, this is despite that I mean, Dr. Mirza would vouch for that. I mean, primary healthcare system in Pakistan was something which we used to be proud about. We have an elaborate system of basic health units, but unfortunately, majority of the basic health units, you have बकरियां और गाय वहां पे बांधी जाती हैं rather than the doctors. So then the second problem is we have ungoverned, totally autonomous general practitioner system, which is not under control of any ministry, any association, any organization, any university, and they obviously doing business on the street, so they would do what benefits them. Okay, but then there is another problem. So this is the other problem which we have, which I got this term of KOL. I'm not sure if anyone would know what KOL is. Okay, so I got this term from the pharmaceutical companies. So when they are talking about how to contact physicians and whom to invest in, they say, okay, we want to talk to KOLs and we want to invest in KOLs. So it's key opinion leaders in their. So who are key opinion leaders? They obviously learn from international experts and literature, but importantly, what they have is they have influence on their trainees, but more importantly, they have influence on general practitioners. And this is not something new. I mean, way back when I was a medical student, I was working under Professor S.M. Rao, a renowned physician in Karachi. And I know his prescription used to be waited for and copied by general practitioners that रब साहब ने ये दवाई लिखी है, अब हमें भी ये दवाई लिखनी. उनको पता कोई नहीं होगा कि ये दवाई क्या चीज़ होती है, लेकिन बहरहाल वो रब साहब. So that's why I think a pharmaceutical company would tell me that I can fund your travel to ACC or ESC. Although, I mean, how many patients I see per day? 18, 20, 15, 10? But my prescription has an influence, so that's why they want to invest in me. But in return, what we create is a large egoistic people like me. I mean, I think we have big egos. So because of that ego problem, none of the hospitals in Pakistan, even the best hospitals like Khan University Hospital is one of the best hospitals we talk about, have a protocol-driven management, because the two cardiologists there cannot sit down together and agree on what the other person is saying. They'll say, okay, what I know is better than the other person. And there are no referral centers of excellence. If there is rare procedure which have to be done, why everyone has to be doing that with, say, one procedure in a year and not really be proficient in that procedure? It will be much better if there is one center in the whole province which is doing those rare procedures, but we can't do that because it's not in my ego. How can someone else be doing the procedure and not me? So I think apart from the healthcare system and the government we talk about, I think we have a big problem within ourselves, which we should be talking about. And I think the reason I'm saying all these problems is because if we want to try to find a solution, we first want to know the problems. If we just keep on talking about the prevention, prevention kabhi nahi hogi, because the issues which are like them, they remain the same. So we know that we need to do all these things. So how can we do that? The first thing is we need to have much broader collaboration. And I would like, I mean, now lifestyle medicine to start, like, I mean, I think example from Thailand, collaborating with other societies, cardiac society, hypertension league, medical society, be part of that. No one, I mean, there's hardly anyone, at least from my cardiology colleagues, who know about that there is a specialty called lifestyle medicine also. Although it's there, all there in our country, but people do. So that's what we need to do, that we need to build broader collaboration. And I think that's another area where maybe lifestyle medicine can pitch in, that in cardiology institutes, if we are setting up preventive cardiology units, lifestyle medicine becomes part of that or actually runs those units, right? So that's another thing where where I would need to make a caution, because at this time, this is in Pakistan, if you see, maybe even abroad as well, this is an area of specialization. Okay, you will find a cardiologist very easily, you will find a gastroenterologist, you find a neurophysician, but it'll be difficult to find an internist, because everyone wants to specialize. I mean, who wants to remain just a normal poor cardiologist? So that's what we need to change. I hope lifestyle medicine does not become another specialty where people do post-graduation to, I mean, have their board a little bit. It becomes part of every specialty and teaches them what they need to do rather than what they have not been able to do. I mean, I would say that as cardiologists or cardiac society, we have miserably failed in preventing cardiovascular disease, but maybe this injection of lifestyle medicine now can help us rejuvenate our efforts to do that. Okay. Just one point I am going to say again, I think, I mean, I'm complaining about myself all the time here. So, because I think वो कहते हैं कि मेरे दिल का दर्द है, मैं सब अपने कार्डियोलॉजिस्ट से भी कहता रहता हूँ. We talk about patients कि जी हम कैसे जाएंगे, लोगों को बताएं, वो सुनते नहीं हैं. बट जो पेशेंट हार्ट अटैक के साथ आपके दरवाजे पे आया हुआ है, उसके साथ तो बात कर लें. Is it not criminal for us कि हम आप आज आया, स्टेंट डाला, कल डिस्चार्ज कर दिया, छुट्टी, अल्लाह खैर, I have done my work. Is that complete work? I don't think this is a complete work. But we need to have, and that's something where I think our government and our maybe provincial government now, health and domain, they need to think about that we need to change the method way we judge the performances of the hospitals, not the numbers anymore, the quality what we provide them. So in acute MI care is not just putting a stent in, it's a package which includes prevention after that as well, and medication what need to be taken after that. And I think reimbursement, whether it is a private hospital or a public hospital, this is another major issue which we need to take out of equation some other, and that's reimbursement. Because your procedures give you a reimbursement. I talk to the patient on exercise, that doesn't give me much money. I mean, why should I spend half an hour talking to a patient, whereas in 10 minutes, I can just write him 2 tablets, 1 vitamin, and see 6 patients in those half an hour rather than talking to. So we need to change that. Some other need to change that in our system, where reimbursement is, at least in public hospital, not on procedure basis, but as a package, which includes all this thing, and maybe lifestyle specialist becomes part of that team when it happens. And I think as far as the drugs are concerned, the cost of medication, I just wanted to share this one issue. I mean, and this is something which we probably need to think about, because that will significantly improve the compliance of the patient after having a procedure or an MI, and also the cost of medication. But again, I think one of the major issues, I've been talking about this poly pill thing in Pakistan, and every time a pharmaceutical says, I mean, we can't, it's available in India and in some African countries, but until they are available in America or European countries, DRAP is not going to accept that. So, I mean that, but we need to, I think, keep on talking about this thing, okay? Okay, so I think the last thing which I wanted to talk about, and that's something again which we need to talk about, I think most inadequate thing which we do is advocacy. And the reason we are so poor in advocacy is that we are not on one platform. So that's something which we need to do. And that's what my session to lifestyle medicine, don't create another specialty, gel all the specialities together and work for the betterment of our population. Thank you very much.
Thank you, sir, for such a nice talk. And I agree with you on the egos. I'm sure you will agree as well. We cardiologists have big egos. I've worked in UK for 20 years, and I faced the same thing in district general as well as tertiary centers theirs as well. They don't agree on one thing. Well, let's hope one day they do so. So we move on, and I think I've messed up with my papers.
Meanwhile, can you ask 2 questions?
Ask me questions? No, yeah, you can. Yes.
Thank you very much, Dr. Kazmi. I really enjoyed your talk. Probably you were not there when I spoke this morning. Yeah, so I picked up many of the issues that you have mentioned, especially those which are related with health system. And our answers are in health system, actually. 3 quick points, one directed at you and one at the Dr. Shagufta and her team. First is that IHME data that you presented. The latest data is available now from 2019. So you are presenting until 2016. Secondly, I was wondering that somebody like you who is at NICVD and you yourself saying that the tertiary level state-of-art cardiac centers are being built, and even in those centers, the preventive cardiology is not does not get its due space. So why? It is not possible for somebody like you to convince your management in NICVD, which otherwise, as I agree with you, they're doing a marvelous job, but still, why it is not possible? Partly I know the answer, but I want to hear from you that what the struggle has been and why still it has not been possible. Thirdly, I wanted to share a perspective about polypill. That's a very, very important point you made. And I remember from my World Health Organization days when I was in WHO headquarters in Geneva, the discussion about polypill came to the expert committee in WHO. And the common sense of it is very convincing. And yet the expert committee could not agree that polypill is a good idea. And the reason for that was that the members of the expert committee were lobbied by the pharmaceutical companies, and pharmaceuticals company of not small stature, but the big pharma. So big pharma is the biggest enemy of polypill, because they do, by producing individual medicines, they make much more money than actually producing a combination of very simple generic medicines and produce one polypill which can be transformative in terms of preventive healthcare in cardiology. The last point which I wanted to make was that, and I agree with you, our DRAP will not agree with it unless it is available in some country with stringent regulatory authority. That's given, and I don't blame them for that. I think Dr. Kazmi made a very important point. It sort of echoed me, although he didn't hear me, that I think we have to transcend from this thinking of becoming a specialty in lifestyle medicine. And it should be a cross-cutting theme, which should, common string, which should bind all our health system. And we should be, so the point that, additional point that Dr. Kazmi made was that you should also, lifestyle leaders, lifestyle medicine leaders in Pakistan should also join hands with the different professional societies, in cardiology, in diabetes, in cancer, etc. But then the question to you is, do you think that these societies are also not playing in the hands of pharmaceutical companies? And do you think that they will be professional enough to actually equally collaborate with something so benign and so not for profit, in terms of the commercial side of it? So I would be very interested to hear from you.
Okay, thank you very much. I mean, I think all of these questions are still questions for me as well. So, coming back, I think from the societies, first thing is the reason I thought that we need to start talking to other societies as well is that we need to have this approach going across the disciplines. So one way of going through the discipline is going through the societies. So like, I mean, I've already thought that we will be calling one of the office bearers of the society to our cardiac society annual meeting in November, so that more people listen to what we need to keep on saying it. I mean, I understand we're not probably making that much impact, but we need to raise the noise level to a point that some people start listening to what we are saying. So that's why I think it is important to build the other societies and other disciplines. So that was my point. I am sure it's not going to be easy. The other point about pharmaceutical companies is, I think, again, the reason I showed this example of KOL is that I think we are actually in a very, very highly materialistic society. And problem is not just pharmaceuticals, problem is us as well. So we individual level as well as collective level, we are problems as well. So healthcare, I think the day, unfortunately in US it happened, when they declared health as an industry, I think we went into this downhill kind of slope. Well, I don't think we really have any quick or good answer for that. But again, my answer is same thing, that you try to keep on doing what you think is right and try to build the noise level so that people are forced to listen to what you are saying. So that is my point. As far as polypill is concerned, I totally agree. But the study I showed was, I mean, polypill is being used for two set of people. One, primary prevention, high risk population. And there are questions about that, but a lot of convincing data which has shown that works very well. In India, in Iran, Poly-Iran is a very comprehensive study. But the study which I showed you is a multi-center European study, and it is not for primary prevention, it is secondary prevention. So my point is, at least let's talk about this small set of people, because 1/3 of your people who are coming back with an acute MI are those who already had an MI. So let's start treating that. Now the last point and the most difficult point, which I've been struggling with 5 years. So I had set up Department of Preventive Cardiology at NICVD. We made some progress. Now I was the single one for 3 years. Now we have 3 faculty members and some resources as well. So we do some clinics. But the problem is again that materialistic approach. You have to show to the government that the funds you are receiving, you are doing something. Prevention doesn't show immediately. So chest pain unit does show. PCI volume does show. So it helps you get even more budget. And then you get into that vicious cycle because you got more budget on that premise. You have to do that and even more than that. So from 1 chest pain unit, it became 17 chest pain units, right? But unfortunately, when I say that discharge patients on at least statin for 2 weeks until they come back, say we don't have money. We have money for stent, but we don't have money for...
I always say, and I don't say this lightly, that we have to make preventive medicine very sexy so that people pay attention to it. People simply don't pay attention to it because it is not sexy enough.
Yes.
Another task for family medicine to, lifestyle medicine to pay attention.
Another question? Yes.
Can I make just a comment about the preventive cardiology? Because the problem is for the preventive cardiology.
Ma'am, mic.
Medical University. So we tried our best to create a post for the preventive cardiologist. But you see, the problem is this. There is no service structure for preventive cardiology, one thing. And secondly, the criteria of PMDC is so stringent that we were unable to get a qualified preventive cardiologist. So the 2 things. And thirdly, our tertiary care hospitals, they don't have space for preventive cardiology because preventive cardiology, we have like spent 6 months to 1 year. But we were unable to find a place and the qualified preventive cardiologist. This is one thing. Secondly, sir, you talked in the morning that we are the 5th most populous country. And so all those things, even you have, if you have the budget and all the things, only what I very strongly feel that unless we control our population, that is the tsunami which we are heading. And now it's after the devolution, it is the provincial problem now. And the third is NFC what is on the population. You show more people, you will get more money. So this is the issue. Thank you.
Thank you, ma'am. Yes, and I think it all comes down to our primary and secondary care system. Obviously, all the load is on tertiary care as well. It has to be divided. It has to go from even in the West, when somebody gets a PCI, they need cardiac rehab. So they get referred back to the district general hospital rather than staying in the tertiary centers. So we need to strengthen our district generals, our primary healthcare, and there onwards we may be able to move with preventative measures more. Right? We move on with our last guest speaker, but not the least, Dr. 𝗟𝗲𝗄𝗏, who is a public health physician with expertise in social and behavior change. With expertise in social and behavior change integration within health systems. He holds a Doctor of Public Health from George Washington University and has served as Senior Global Technical Advisor for Pathfinder International, managing USAID investments across 11 countries. He has been a faculty member at Aga Khan University, supported WHO's SRHR Research Hub and currently Secretary General of the Population Association of Pakistan. We welcome Dr. 𝗟𝗲𝗂𝗲𝗏 to the stage to speak on health behavior theory application in clinical practice. Thank you.
Assalamu alaikum, everyone. I'm going to change the mood a little bit. We've been talking about systems and integration and the profession of lifestyle medicine as a whole. And I now want to maybe focus a little bit on our practitioners who are somewhere there and have been very quiet throughout. So मैं अब थोड़ा micro level पे आना चाहूँगा. The point that I want to make is, I think a lot of people have said things that have set the stage for what I want to say really, really well. जो एक presentation थी, उसमें they said कि social determinants of health को हम account for अभी तक नहीं कर सके properly, या cultural adaptations जो हैं वो local होने की ज़रूरत है. And what I want to talk about is how can the discipline of health psychology and health behavior theory be applied in more one-on-one clinical settings. This is more about the practice of client counseling and facilitating behavior change. So I'm going to walk through this, and specifically, I want to talk about 2 or 3 different aspects of it. So this is, if I'm successful in getting my message across, at least some of you will become interested in theory beyond what you already know and would want to learn more. So if I can do that today, I think I've achieved my objective at least. So I want to start with the confession that for many years as a clinician, I was guilty of talking at patients, lecturing them, throwing knowledge at them, bestowing my medical wisdom upon them. And it was many years later that I actually discovered, can I have the next slide, please? That I discovered that this is what the, sorry, I can't, this is what the revolutionary educationist Paulo Freire called, 𝗟𝗶𝗳𝗏𝗄𝗏 slide, please. This is what he called the banking concept of education. Can you have the next slide, please? अच्छा कुछ हाँ ठीक है अच्छा नीचे पे आगे जाएगी okay, this way, right? So and in his book, this image is from his book The Pedagogy of the Oppressed, where I feel I was guilty very much of the same, and a lot of the clinicians and a lot of the OPDs kind of practice in the same model, where clinicians and doctors and counselors are all knowing saviors who will save patients and clients from themselves by bestowing their medical wisdom upon them. Now, for those of you who are practicing, just by a show of hands, how many of you can claim that at least 50% of your patients follow your advice and end up changing the behaviors that you need them to change effectively? At least 50%. So we'd love to know exactly what you're doing to make that happen. But if we were to ask you to share your evidence on how you achieved that so that others could leverage that, would there be discussion of theory in that? Absolutely, right? So what I am hoping to share today is how that can be used to strengthen client engagement in clinical settings. And of course, this banking concept of education is pervasive across the medical profession. And what this fed into eventually, sorry, can I have the next slide, please? 𝗟𝗶𝗳𝗏𝗄𝗏 slide, please. Right. So in the course of my discovery of what makes people change and do the things they do or the changes that they make, I was introduced to Paulo Freire. And in the same book, Pedagogy of the Oppressed, he says something that has stayed with me for all these years and has been my guiding beacon for any work that I undertake on health systems or linking it to social and behavior change. In a very poignant stance against Locke's concept of tabula rasa, Freire states that nobody is a blank slate, that everybody is an individual created by their experiences and impressions, and that women and men can learn through learning to make and remake themselves. Freire states that women and men are able to take responsibility for themselves as beings capable of knowing that they know and knowing that they don't. And this has been the foundation for what has been termed as participatory education. Can I please have the next slide? 𝗟𝗶𝗳𝗲𝗍𝗍. Yes, participatory education and communication. I'm sorry, the font is a bit off. But participatory education in itself is a process which deploys tools aimed at engaging individuals in participatory reflection and analysis to assess and analyze their own needs, priorities, lives. And it is aimed at empowering individuals to make those choices for themselves. And the educator or the clinician or the facilitator, their role is to facilitate this process, facilitating them to come to those conclusions and decisions that are much easier to just say to them, but are not owned by them if that is what is needed. And let's keep in mind that lifestyles and behaviors are not something that are happening within an individual's lives. They are shaped by centuries of history and anthropology and lived experiences that are transferred generation to generation. So telling somebody that you've been doing this and this is not appropriate, do it differently, is not going to make that impact. Knowledge does not translate into behaviors and action. Can I have the next slide, please? Now, for a wide variety of reasons, the clinical encounters or the OPD encounters that take place in most of the medical facilities, they are generally one-sided. They are generally one-sided, with information flowing from the clinician to the patient. And even when patients are allowed or encouraged to speak, that is restricted or limited for the most part to details about their history or their background, or allowing them sometimes to ask questions. And yes, that works, but if we want to move towards a more Freirean participatory methodology, that requires a two-way interaction with the, next slide, please, which requires that it is the client who engages in this conversation. The client leads this conversation. You see the bigger bubble is on the left. The role of the clinician is to facilitate that thought process. Now, this process, can I have the next slide, please? This process requires a systematic and structured stepwise approach that is co-created between the physician or the facilitator in Freirean terms and the client or the individual. And what I'm sharing with you here is this is my preferred 7-stage behavior change cycle in clinical settings. There are very many variations of this. Some have fewer stages, some have more. This is what I have become accustomed to over the years, and it ranges from what you probably understand and already are aware of, ranging from screening right down to evaluating outcomes. Can I have the next slide, please? Now, this entire cycle, theory, or at least theoretical concepts, they permeate the entire cycle in all stages of this cycle. Yes, thank you. Now, as we move through these stages, there are different elements of theoretical applications that emerge at each stage. So even within screening, there are theoretical applications related to reference information. For selecting a target behavior, very often as medical doctors, we know what the patient needs to change, right? But does the patient agree with you? And selecting a target behavior in itself is a bit of a challenge, because for any number of medical issues, the behaviors that require changing are not singular. There are a multitude of intersecting behaviors. So assessing behavioral priorities and selecting behavior targets also requires the application of theory-driven concepts that assess readiness and willingness to change. Not everything can be undertaken immediately. Allowing the client to assess their willingness, readiness, assessing their own ambivalence and discrepancy about the need for change would help the process of reflective analysis within the client. Now, the first tangible application of theory comes at the diagnosis stage in stage 3, and its application in stage 4, and I'll speak about that in a little bit more detail. But these two stages that leverage theory-informed thinking, which is capable of predicting or at least postulating a change mechanism, they inform what is a behavioral contract. And when I was learning this, my mentor said, if you skip the behavioral contract, it won't happen. That contract signing is that commitment to change. And that in itself is a trigger, is a nudge for the individual that, yes, I agree, this is my commitment. And it creates a much more conducive environment to move forward as we engage with the clients in weekly monitoring and coaching sessions, which look at progress review, reinforcement and contingency review, as well as troubleshooting that eventually leads to evaluation of the outcomes and objectives. Now, keeping in mind that as we develop the robust behavior change plans in stage 4, there are client-focused monitoring tools that need to be developed on specific outcomes and behaviors that clients need to fill out themselves and bring to the consultations each week. That process of tracking that numeric data on what was agreed is that reflective tool that is critical, and very often it may be missing from these OPD interpersonal encounters. Can I have the next slide, please? Now, the 3 diagnostic levels that are mentioned here, the first one is really what I will be focusing on, which requires the application of health behavior theory specifically. The other 2, health and wellness, has its own set of theories to look at. They have their own reliable, validated health and wellness inventories, which offer a lot of insight into the ecology of behaviors that are explained qualitatively through behavior theory. And of course, for individuals from case to case, on a case-to-case basis, there are other domains and traits that may be assessed using existing scales, such as social support, anxiety, stress response, and things like that, because they help us understand and create a full picture of why an individual is doing or not doing what we are discussing as lifestyle modifications. Can I have the next slide, please? Now, while there are many different classifications and categorizations of theory, I like to think of these from a practice-oriented perspective as 2 broad categories. Now, not all theories will be applicable in an interpersonal setting, but the ones that are applicable, they either look at behavior change as an event or behavior change as a process. Now, depending on the behavior, you may pick one or the other. However, the same behavior may be looked at as an event followed by a process. So theories can be modified and adapted to the nature of the behavior itself. Can I have the next slide, please? Yes, so as I studied behavior theory, and it fascinated me because suddenly I had a structure within which to start understanding individuals and what they're thinking, and things that could be measured as well. Because if we are not measuring something, well, does it really exist? So these are some of the more common critiques that have come my way every time I've tried to talk about theory, particularly with health systems folks who are not very fond of behavior theory at all. And there's a lot of pushback when you start talking about that, including, sir, from WHO for that matter, and they've just started their own behavioral science unit. So that's a good change and a positive shift. Now, these are the 3 main critiques that I've come across. And I will speak to that towards the latter half, where I'll try and break down a theory to sort of unpack with you how to unpack a complex theory. But my most favorite critique that sort of triggered this whole journey of discovery in theory was, can I have the click, please, was that these theories were always deemed too Western, developed by Western individuals, for Western populations. These concepts don't apply to us in the global South or in Eastern populations. And what that did was it sort of got me thinking, and I started looking for rationale for why these concepts are about human nature, and human nature is human nature, regardless of where the people live. Qualitatively, things might change, but all humans have the same sort of systematic structure within the wiring of the brain and our responses. So When I started digging in, can I have the next slide, please? I found that the first psychologist to talk about human behavior was Imam al-Ghazali in the 11th century. And in his treatise on nafs, and to understand human beings, on why they do the behaviors that they do, he describes the first behavior change framework that is out there, and unfortunately it's not very well known, but he describes human behavior as being foundationed on intellect. If a person has the right intellect, the right cognitive ability, they will acquire the ilm needed for that behavior. And if they have that ilm and they have positive feelings or qalb towards that behavior, and if they have ikhtiyar, they will voice irada. And individuals who voice an irada will go on to complete the amal. And of course, when we were, that gentleman said it, I'm repeating it, thank you, but you know, when I tried to bring this into the domain of practice, one of the things we discovered was that irada was easy to understand and explain. It's very much a part of the local cultural context. One of the earliest things about irada that I remember, when we would go to say our prayers in the mosque, they would invite folks to go on tabligh, and people couldn't go, they had work and stuff. They would say irada kare, Allah rahe nikalega. So irada is a very culturally ingrained concept. And 1,000 years following this discourse, everything was silent, everything was quiet. Nobody talked about human behavior or psychology for another millennium. But somewhere starting in the 20th century, particularly in the latter half, there was an explosion of behavior theory, and health psychology sort of started making its mark. And as you can see at the top, between the 80s and 2005, there were almost 150 new theories that were discovered or proposed. And the application of these different theories, the tick marks that you see is how frequently or how common each theory was described in literature over the years. So this field has been evolving. It has so much empirical evidence supporting it and its application, and it allows us to standardize approaches. However, there was a paper written in 1987 called The Two Cats of Kilkenny. And that paper was about how the health systems folks and the health psychology folks, they don't want to speak to each other. They just don't want to get along. And that has not changed. So for somebody who's coming from health systems and policy and decided to study SBC and social or behavior change, I have more than one story about the arguments that I've had with health systems individuals on why, without behavior theory, health systems don't make a lot of sense. But that's another argument that, of course, is still open to debate. Now, but why use theory? Really, what does it offer? Can I have the next slide, please? So if you look at this slide, on the left, you see a list of, it's not an exhaustive list, but it's a list of the more common concepts that we identify and describe as being behavioral antecedents that feed into people's decision-making. Now, if we were to take history from a client, just open-ended, list down what we find out, and we classify them as different concepts, you would get some of these that are shared by the client themselves. Now, if you use a theory, you will be able to say, all right, this model says, this is what drives behavior. I have elicited certain things from the client which cover these concepts, but the theory says there are 3 other concepts that are also important. So let me unpack those with the client. Very often, the client will tell you what is salient to them, but there are lots of other nuances that drive behavior that may not come to the forefront if you have not brought in a structure to describe or understand why behavior takes place in the manner that it does. So on the right, you see the integrated behavior model. That's the latest iteration that came out in 2008. Funded by the NIH to bring all the existing theories together. And on the right, you see the theory of normative social behavior. So the integrated behavior model is most comprehensive, and I will just show that to you in a minute, and you'll see how Imam Ghazali's work is reflected in this model. But on the right, you see the theory of normative social behavior, which has very few concepts in it. But that theory is aimed at explaining how observed behaviors of others or descriptive norms can predict behavior change in individuals. We know, right? They say monkey see, monkey do. People, when they see somebody doing something, they will replicate that behavior. Now, the last one on the right, it predicts how that observation changes into them adopting the behavior themselves. So it gives you a pathway to understand the behavior change itself, but also what interventions may be needed to shift individuals from that space where they observe a behavior among others, but then what would you need to do to facilitate them to adopt that behavior at the same time? Can I have the next slide, please? So this is the integrated behavior model, and you'll see that intention is the primary predictor of behavior in this. And there is a ton of empirical evidence which keeps repeating that people who voice intention are more likely to engage in the behavior compared to those who don't. And intention in itself is predicted by things like a person's thoughts and feelings, how they think about a behavior, how they feel about that behavior. It's also driven by their perceptions of norms. What is their expectation of social approval or disapproval? What is their level of, what is their perception about the level of prevalence of that behavior in individuals who are their peers? And these two together, combined with personal agency, again, reflective of what Imam Ghazali called ikhtiyar, will define or determine intention. So the first half of this tells us why people develop intention, and the second half tells us why they go on to fulfill that intention to do a certain behavior. Now, a lot of the critique on this model, of course, and others as well, has been that this is way too Western. But when I first looked at it, I thought this is very much aligned with what Imam Ghazali said, and Imam Ghazali wasn't in the West, so surely there's got to be some applicability. Secondly, Dr. Fishbein, who's the author of this model, he argued that the variables at the back end, individuals' feelings, thoughts, perceptions, and control beliefs or efficacy beliefs, they would vary as a set of background variables for the population changed, but you would have these beliefs in all individuals across all societies. Their qualitative nature might be different based on the geography or even based on the behavior itself. So with that in mind, we set out to prove that empirically. If you don't have empirical data, it's hard to prove your point. So we went ahead and we undertook a study in which we thought we'd use the IBM and we'd work with local women in the community, looking at particularly adoption of contraception and family planning. And we tried or attempted to translate the whole IBM, change it into questions, and then measure and validate the framework. So I won't go into the whole study, but I do want to share with you what the translated version of the IBM looked like. Next slide, please. So this was how we ended up translating it. This was not a unilateral sort of translation. We worked with women in the community, explained the concepts, got feedback on what concepts they understand based on the definitions of these, and this is what we got. So experiential attitude or feelings were represented by qalb, defined by Imam Ghazali originally. Aql was cognitive or instrumental attitude, and together they form what was referred to as ravaya or attitude. Now, why we needed to do this was because our field workers who were working in communities, going door to door, counseling women, if I sit in my office and think about behavior theory, but I don't explain it to the counselors because it's English and it's complex, then I'm creating a gap in the system. I'm not really making a shift. So we had to take the theory to them in the language and concepts that they understood. So they helped us translate this. And I won't belabor this, but you can see that the entire framework from Fishbein translates into locally understood concepts. Rivaj and Riwayat, we were able to distinguish between the two. What I think people will approve versus what I think people are doing. Similarly, khud mukhtari and khud etmadi feed into what women term zati ikhtiyar. And of course, irada is intention, so on and so forth. Now, what this helped us do was also define what beliefs to assess, to understand what's the gap and what's the barrier that's preventing women from adopting contraceptive methods. And based on this, our field workers were able to develop rapid questionnaires, go door to door. In their household level engagement, they would identify where the scores are low and then focus on delivering key messages for those domains specifically. Now, this isn't happening in a clinical setting, it's happening at the household setting. So that's my first message. Behavior theory is not too Western. It's about human nature. What's needed is the will to apply it and to translate it. If we have that will, it will manifest. Now, the second piece about it being too technical, and I will try and explain, can I have the next slide, please? And I will try and explain this model, which I'm sure a lot of you are familiar with already, the trans-theoretical model or the stages of change model, very commonly used. But just looking at it, it's confusing, right? It's very confusing. It's difficult to get your head around this in just that visual. So what I'm going to do, I'm accepting this challenge of complexity, and I'm going to explain the trans-theoretical model to you in 2 minutes, or maybe 2 minutes, 15 seconds, but still, it's still short. I'm sure. So let's see. So one of the tricks about behavior theory is, if it seems complex, the go-to solution is break it down. Break it down into its component parts and look at each one individually. As you walk through it, it will all come through and it will come together and explain things to you. Unless you break it down, it will always be confusing. So next slide, please. I'm going to go through the concepts of the TTM very quickly. It has 4 key concepts, the stages of change. Key, please. Isme animations hain aap? Haan ji. Next slide. So the stages of change are 6 key. And they're self-explanatory. In many ways, they look like the IBM themselves. So pre-intention, intention, action, and maintenance. It accounts for relapse also. So it's really good for behaviors that have behaviors as a process, right? So smoking cessation, exercise, diet, all of those behaviors would be very well explained by that. And that's the first concept. Next, please. And then the next 2 concepts are decisional balance between pros and cons, as well as self-efficacy and the balance between self-efficacy or confidence and temptation. Next, please. So we see that during the process of change, following motivation and engagement with individuals, there is decreasing cons and increasing pros for that behavior. Now, even if you have your first interaction and you ask them to list the pros and cons, you can start tracking these as they change over time. And we see that as individuals move from intention to action, you can see their self-rated increases in self-efficacy and their self-rated decrease in temptation for the behaviors that need to change. And this helps us to do sort of like a monitoring shift. So a person can do a behavior to please you, their clinician. Patients always want to please their doctors, right? That's the courtesy bias that they bring in. So they'll tell you, I've done this. But when you assess them for their pros and cons and self-efficacy and temptation, you'll see that if they're not aligning together with their stage of change, there's probably something wrong that you need to unpack. Now, the final part of this theory are the processes of change, and there are 10 of these. And these are what will really help you decide what does the patient or the client need during your interaction to facilitate them to complete and maintain that behavior. And next slide, please. Now, these are 2 types, click. So the first of these are experiential processes. They're more about feelings and emotions and thoughts. And these are aimed at moving individuals from pre-contemplation, contemplation to intention. And the second half of these processes are aimed at facilitating individuals to initiate action, maintain it, or come back to it once they've relapsed. So next slide, please. Now, this is a full list. We don't need to go through this, but I just want to show you that there's a clear demarcation of these concepts. And depending on the stage of the individual, once you've engaged with them and identified what stage they're in, it helps you create that line of demarcation as to what you need to consider for this individual. Is it next कीजिएगा और फिर वो slide animate करने. So do you want to focus on these, or do you want to focus on strategies which facilitate counter conditioning or helping relationships? Are you going to focus on stimulus control or reinforcement management? And that is what the TTM can help you do. It can help you structure your process, your thinking, revisit it, tailor it and customize it to a whole range of individuals, and also measure the progress from your clients. So the key takeaways, from me for today are straightforward and simple. Please, आखिरी slide पे जाइएगा, दो दफा. Next, yes. No, back. This one, right. So first of all, it's not a freestyle engagement with your client. It's not just about conversations and counseling. It requires a systematic and structured approach. It requires you to document that approach. And please, I know it's very tempting to not document before you begin, but there's no success without that initial planning and documentation. Always adopt a theory-driven thinking across all stages, not just for health behaviors. Work with your clients to co-develop your simple monitoring tools that they can fill easily and review with you in your sessions. Practice participatory approaches during sessions. Make sure that you are asking questions and creating triggers and allowing the client to speak rather than giving them the information, and wait until they ask you for the information before you share it with them. Strive for data-driven discussion using monitoring tools. Nothing creates as much reflective analysis in individuals as looking at their own progress and being able to unpack it with you as the facilitator. Your reviews should be frequent. They shouldn't be too far out spaced. And your contracts that you engage with in clients, they shouldn't be too long drawn. They should be short-term contracts, 6 to 8 weeks, to be revisited and recreated every 8 weeks or so. That allows you to breathe and pause and be better equipped to respond to those very nuanced factors that may be very different for everybody. Thank you very much, everyone, for your patience.
Zahir, thank you very much for this presentation. I really enjoyed this presentation because I've been handling patients, so this behavior change theory is very important for me. And this was taught to us during our IBLM exam preparation. My question is, though I don't know whether, I think it is not directly related to you, but this out of curiosity I wanted to ask, because you have been reading probably about niyat and irada and qalb, as you have shown us the slide of Imam Ghazali. I wanted to ask you, do you have any idea where this concept of niyat and irada is located in our brain? Do you have an idea? Is it the limbic system?
Mera honest answer ye hoga, Dr. Gupta. I don't think it's located in any one spot.
Okay.
I think it's an amalgamation of thoughts and feelings and beliefs. So at some level, it is your neocortex. At other parts, it is your limbic system.
Okay.
It's also your septohippocampal pathway, because memories and the traditions and histories that you absorb from your family, which become very hardwired, they also feed into this, right? So an interesting sort of phenomenon that I sort of want to talk about is that when we asked women whether they believed that contraception was permissible in Islam, when we asked them, is it haram in Islam? Everybody said yes. So we changed the question. We said, is it permissible in Islam? So about 30% agreed that yes, it is permissible. 70% said no. But in the same questionnaire, our question on intention was, do you plan on using contraception? Do you intend to use contraception? 75% said yes. So what we learned was private behaviors are very different from social behaviors. And people may believe one thing, but go on to do another thing, depending on whether they're being observed or not. So I can't say that it's located in only one place.
I have done a very, very small study on a small group of patients that when we fast with niyat, when हम जब रोजा रखते हैं और नियत कर लेते हैं, the body doesn't suffer. But when we fakofy, we don't eat anything and we don't niyat, yani we don't utter those words, the body ज़्यादा damage होती है. So I am still finding.
I think it's the frontal cortex which helps you reappraise the situation and adapt to it.
Frontal
cortex. If you have intention, if you've done niyat.
Okay.
It's your cognitive part of the brain which helps you to do cognitive reappraisals.
Right.
If you were not being, if we were sitting here and you didn't give us lunch, we'd get very upset.
Yeah.
Right? But if we are fasting, it's okay if we don't eat, because our frontal cortex is doing cognitive reappraisals.
Okay. Thank you. Thank you very much.
Please.
Get a health behavior change on health issues, or as you did a survey on contraception. So I always wonder that once there is a change in like shirts are long or shirts are short, within days you will see that everyone is wearing the same. So how will you would you like to?
Right. Conformity is a state of comfort. Conformity is a state of comfort. When human beings are, I think, programmed to align with whatever they're seeing others doing. So observation of what others do is a very powerful medium. And what you have just described is the power of what we call descriptive norms. So, right, injunctive norms are whether something is approved or disapproved. So the perfect example is for teenage smoking, right? So teachers and parents and everybody who's in authority will disapprove it. They know they can't be seen smoking in front of those authority figures, but at the same time, they observe other young people engaging in that behavior. So despite that disapproval, the power of what you see others doing is very important. मैं example आपको इसका इस तरह दूंगा. If you're walking down the street और आपके पास कोई खाली थैला चिप्स का या जूस का पैकेट है जो खत्म हो गया है और आप गुजरते हैं तो आप देखते हैं सड़क के साइड पे कचरा पड़ा है. You are more likely कि हाँ ये कचरे की जगह है, इधर फेंक दो. अगर आप जा रहे हैं और वो जगह साफ है तो आप नहीं फेंकेंगे. Well, most of us, but the reason being because जब वो कचरा नजर आता है तो your brain says, oh, everybody throws garbage here, throw it. Versus जब वो साफ है तो brain कहता है नहीं इधर तो कोई नहीं फेंकता, मत फेंक. That is why we were discussing that a lot of Pakistanis who live overseas, their social behaviors are very different from the minute that they land at the Pakistan airport, right? It just changes completely. It's the power of descriptive norms, observed behaviors of others.
Thank you very much, sir. You indeed gave a very great talk, and you are a very useful person. I need to sit with you on dinner because I've got the knowledge. Teach me the qalb to get ikhtiyar at home.
Sir, I cannot teach you. I can only facilitate the process.
Right. Okay. Right. Right. Okay. That was on a lighter note. Nobody heard that. Okay. Right. So today's conference has, well, obviously, along with Palm, there are other people who have contributed through their hard work as well. And they are some of our sponsors. So they've been outside on the stalls all day, facilitating us, telling us all about their products, and they've worked hand in hand with us to organize this event. So it's time so that we can give them some certificates. I would like to invite Dr. Shagufta Feroz and Dr. Abdul Jabbar to come and distribute certificates amongst our key sponsors. All right, Dr. Munira and Dr. Abdul Jabbar. Right, the first one is the first certificate is for Kisan Ki Dukaan. Thank you, sir. I've just bought some desi andas from them as well, and I'll try how they are. Thank you very much, sir. Next certificate is for Nutricals. They have been our sponsors as well. Right. I think we've all been sitting for a long time. Why don't we stand up whilst we are right. The third certificate is for Ashraf Naturals. All right. Okay. Once again, well, you get the standing ovation again.
लेकिन हम आपके जज्बे की जरूर कदर करते हैं. अल्लाह ताला आपके काम में बरकत डालेगा क्योंकि आप आके फिर भी हमारे साथ आ जाते हैं without getting any benefit out of us. Thank you. Yeah, third year in a row. Yeah, बड़ी बात है जी.
Thank you very much. Thank you, ma'am. Thank you, Dr. Abdul-Jabbar. Right. Okay, I think you people can sit now. You want to stand? That's fine. Right. It's time to move from, obviously the talks had evidence as well, but to some real evidence, some oral research presentations. The first one, I would like to invite Ms. 𝗟𝗶𝗳𝗲𝗄𝗂 from Rifa International University, who would talk on eating behavior, physical inactivity, burnout, and work efficacy among doctors. That is your slide. This is how you go.
Okay,
The downward one is.
from down?
Yeah.
Okay. Assalamu alaikum, everyone. I am 𝗟𝗶𝗳𝗲𝗄𝗂, and my topic of research is eating behavior, physical inactivity, burnout, work efficacy among doctors. Here is a brief introduction about my research. As we all know that the ratio of the patient in Pakistan is increasing day by day, and according to WHO, 1 out of 1,000 doctors and patient ratio. To explore this pneumonia, the present study examines the relationship between eating behavior, physical inactivity, burnout, work efficacy among doctors. From literature review, we explored that there is a lot of burdens on the doctors that is affecting their lifestyle, their health. Here is the objectives of